Beatrice Company for inviting me to speak about their product, Lipitor. Actually, my topic today will be about management of dyslipidemia in diabetes, approaching the most effective intervention. We'll start with a case, Mr. MMA, the 60-year-old man who was diagnosed as having type 2 diabetes 10 years ago. He was initially treated with lifestyle management and metformin. 3 years later, his treating physician advised him to add long-acting basal insulin analog to metformin, reached up to 40 units per day. Other current medical conditions including hypothyroidism. His current medications are metformin 1000 milligram BID, long-acting basal insulin analog 40 units per day, and levothyroxine 100 microgram every day. His physical examination, including body mass index of 32 kilogram per meter square, weight 98 kilograms, and height 175 centimeter. His blood pressure is 180/110 millimeter mercury, mild ankle edema, otherwise unremarkable. His current fasting blood sugar is 140 milligram per deciliter, and postprandial blood glucose is 256, and hemoglobin A1C is 8.5%. Urine albumin creatinine ratio is 950 milligram per gram. Serum creatinine is 2.4, uric acid 8.7. Total cholesterol is 236, triglycerides 200, LDL cholesterol is 140, and HDL is 46, and TSH is 5.1. The question is, what are the medical problems that should be managed in that patient? The answer is poor glycemic control, elevated blood sugar, dyslipidemia, renal impairment and albuminuria, obesity, and old age. So a lot of problems we will not solve it in this lecture. We will catch dyslipidemia. Dyslipidemia in diabetes equal coronary artery disease because cardiovascular disease is responsible for 60 to 75% of mortality in type 2 diabetes. Cardiovascular disease is 4 times more prevalent in diabetes. Cardiovascular disease prevalence increases with age, as so is diabetes. Cardiovascular disease in diabetes is often severe, silent, poor prognosis, and fatal. Diabetes increase mortality, recurrent myocardial infarction, acute coronary syndrome. Diabetes erases the protection conferred to women. At diagnosis of type 2 diabetes, most patients have evidence of cardiovascular disease. Abnormal glucose tolerance is a strong cardiovascular risk factor. So diabetes equal cardiovascular disease. And the cardiovascular risk factors in people with diabetes include dyslipidemia, hypertension, hyperinsulinemia, central obesity, cigarette smoking, hypertriglyceridemia, and postprandial hyperglycemia. And when we are looking about the causes of this in diabetes, we will find that coronary heart disease or cardiovascular mortality correspond to 46% mortality. In the Oasis study, when comparing mortality related to diabetes, we will find that people with diabetes and cardiovascular mortality have the highest rate of mortality as regarding other categories. When we are looking about the predictor of cardiovascular risk in diabetes, we'll find that microalbuminuria, age, waist, circumference, lipoprotein A, and LDL cholesterol are the most common predictors of cardiovascular risk. And when we are looking to dyslipidemia in diabetes, we will find that diabetic patient has certain features of dyslipidemia, including elevated total triglycerides, reduced HDL, and small dense LDL, and LDL level is not usually high, and HDL, as you know, is very beneficial, or has a beneficial role that has a physiological role antioxidant, anti-inflammatory, anti-apoptotic, and antithrombotic. And when we are looking for who to screen for dyslipidemia in adult at risk, the answer is any male or any male or female patients over the age of 40. And if there is risk factors regarding the age, what are the risk factors to screen patients, including clinical evidence for atherosclerosis, abdominal aneurysm, diabetes is one of the most common most important risk factor to screen for diabetes. When we go to how to manage dyslipidemia, we will find that statins is the main cornerstone for management of diabetes, of dyslipidemia, through decreasing the level of cholesterol synthesis and decrease hepatic cholesterol or increase hepatic LDL receptors. So statins are indicated in any patient with LDL level cholesterol more than 190, and the most patient with chronic kidney disease, diabetes, aging more than 40, in addition to atherosclerotic cardiovascular disease. And accordingly, statins have been tried for the prevention of cardiovascular disease in many trials, including primary prevention, secondary prevention, and all are statistically significant, reducing cardiovascular mortality. In the cholesterol treatment trial collaboration that discussing or studying the efficacy and safety of more intensive lipid lowering treatment of lower LDL cholesterol, and the results are statistically significant improvement in all outcome when using intensive control of LDL cholesterol. This is because statins not only have lipid lowering, only it has a pleiotropic effect, including endothelial function dysfunction improvement, improvement in immune modulation, antioxidative action, antithrombotic action, and action of inflammation and plaque stabilization. Despite these facts, according to the EuroSpire 4 trial, majority or most of patients with dyslipidemia does not reach the goal. In the EuroSpire 4 trial, 78.9% of patients receiving statin did not reach the goal. In the DISES 2 trial, nearly 70% or higher of patients receiving statin did not reach the goal. What about Egypt? Egypt the same, about only 34.4% of treated patients achieving treatment goals. Why? As my professors and my colleagues told before, because of many factors. The first and main is doctor inertia. Doctor inertia is very important in delaying the proper effect and the proper control. Also, patients are afraid of statin complications, high interpersonality variability, and if there is very high basal LDL cholesterol. So, what is the role of atorvastatin? Atorvastatin is studied many trials and extensively studied in dyslipidemia. In the CARD study, which is a multi-center randomized placebo-controlled study studying the effect of the primary prevention of cardiovascular disease with atorvastatin in type 2 diabetes, over 2,838 patients receiving atorva versus placebo, and studying the cardiovascular endpoints, as you see here, positive and significant reduction of cholesterol in the atorvastatin arm, with subsequent improvement in the cardiovascular risk factor and vascular outcome. In the TMT trial, which is comparison of the effectiveness of atorvastatin 10 milligram versus 80 milligram in reducing major cardiovascular events. That means low dose versus high dose atorvastatin when studying the effect post PCI patient with a major cardiovascular events. Statistically improvement significant the cardiovascular outcome with atorvastatin 80. And as regarding recurrence of cardiovascular events or revascularization, statistically significant improvement with atorvastatin 80. Incidence of repeat revascularization was statistically significant reduced with atorvastatin 80. What about the PROVIT TIMI 22 trial? This is a trial of early and late benefit of high dose atorvastatin in patients with acute coronary syndrome. As regarding the role of atorvastatin versus pravastatin in composite endpoint of this myocardial infarction and rehospitalization after 3 days, a statistically significant result with atorva. As regarding these endpoints from 6 months to the end of the study, a statistically significant result with atorvastatin 80. Also significant result with atorvastatin 80 versus standard therapy. And this is a simplified approach to the dose of prescribed statin or prescribed atorvastatin. If the baseline LDL is ranging from 100 to 140 and the patient is statin naive, so start with 10 milligram. If the patient previously taking statin, start with 20 milligram. And if the patient, the LDL is more than 50, so increase the dose by 10 milligram. So we will back to our patients. Mr. MMA, what is the cardiovascular risk of our patient? Is it moderate, high, or very high? We will go to the European Society of Cardiology classification into low, moderate, high, very high, and very, very high risk. When we are looking to our patient, we will start with a score, calculating the atherosclerotic cardiovascular risk score. So when we calculating the risk score of our patient, through this calculation, atherosclerotic cardiovascular risk estimator plus, we will see our patient is 60 years, male, race, other, systolic blood pressure 180, diastolic 110, total cholesterol 236, HDL 46 and LDL 140. The patient is diabetic, smoking is never. So the calculated score here is 32.7. Risk of atherosclerosis, atherosclerotic cardiovascular risk is 32.7. Imagine if this patient is smoking, the risk rise to 47.5. So our patient has a risk score of 32.7, and to calculate the estimated GFR, we will calculate it using the National Kidney Foundation CKD API, including serum creatinine, age, height, weight, and the total calculation of GFR here is 37 milli per minute. And according to CKD KDIGO guidelines, he is considered as moderately to severely CKD. And we will back to the European Society of Cardiology classification. We will find our score of patient is more than 10. Score more than 10 is classified here as very high risk. So our patient risk score is very high risk score because the score is more than 10. So what the cardiovascular risk factor of our patient? The risk is very high. So what is the goal of treatment of our patient? To reduce the cholesterol less than 100, less than 70, less than 55. Here, according to the European Society of Cardiology, the target cholesterol level is less than 55. The answer is what is the treatment goal? So the treatment goal is less than 55 milligram per deciliter. This is the last question, and we will try to answer. How would you achieve the target? Increase atorva to 40 milligram, shifting to Resolva, atorva plus ezetimibe as a combination. The answer from the guidelines, European Society of Cardiology 2019, answer this patient: if the patient is very high risk, reduce 2 minutes. 2 minutes. Reduce the A1C to less than 55. So using, it is recommended to use high intensity statin. If not achieve the goal, try to combine statin with ezetimibe. So the options are use high intensity statin or combine statin with ezetimibe. Treatment of patient with old age the same as young. So this is another guidelines, American College of Cardiology, American Heart Association. In any patient with LDL cholesterol more than 90 and the patient who is diabetic, start high intensity statin from the start. And the Cleveland Clinic also the same. If the patient age is 40 to 75 milligram, calculate the risk. If the risk is more than 20, describe high intensity statin, and the same as for primary and secondary prevention. So what are classification of statin? Statins are classified into low, moderate, and high intensity statin. If you see here, high intensity statin, either atorva 40 to 80 milligram, Resolva 20 to 40 milligram, or a combination. So how would we achieve the target? Increase atorva, this is right answer. Shift to Resolva 20 milligram is the right answer, and combination of atorva and this is ezetimibe, this is the right answer, because all are high intensity lipid lowering drugs. Thank you.